I think the main problem is really about the recurrence rate of non-muscle invasive bladder cancer. Despite being a curable disease, recurrence rate on average is still around 30 to 40% in 1 year. So we're really trying our best in order to have different treatment options to optimize the outcome. And secondly, there will be patients who cannot respond to conventional BCG treatment, and classically they might need radical surgery, removal of the whole bladder, which would cause a lot of problems in the future as well. So the other unmet need will be how we can try to control the cancer for those really very high-risk disease in order to spare their bladders in the future. Yeah, I think for non-muscle invasive bladder cancer, there are quite a number of recurrence mechanisms from a clinical perspective. But I just highlight a few which I think is most important. First would be surgery related, whether we can ensure a complete tumor resection, because from the data that we have, up to 30% of the patients still have residual disease despite a so-called complete TURBT. So that's why in some patients we actually would offer a second TURBT to detect residual disease. So we always think how we can optimize the surgery in order to ensure a complete removal of tumor. And in our center, we did a lot of trials on blood resection trying to address this. The second part is more about the tumor biology. Multifocal tumors, with carcinoma in situ, those are really aggressive tumors, and we actually need to understand more about the tumor biology, and likely will need a lot of different adjuvant treatments in order to control the tumor biology in long run. There are quite a few of research presentations on NMIBC. I think the most mature one will be the study called the Sunrise 1 study. Basically, it used an intravesical treatment device. It's called TAR-200. It's like a plastic device placed inside the bladder, which allows a sustained release of a type of chemotherapy called gemcitabine. And they are focusing on patients with BCG unresponsive, high-risk non-muscle invasive bladder cancer. And what they found is that the use of this TAR-200 treatment can actually achieve a complete response of around 83% in 1 year, which is very, very high. So I think with the mature data, likely it will be approved soon, and therefore we can apply it clinically. Oh, we're doing a lot of things. So number one is about the patient selection. So how we can have a multi-parametric assessment from the MRI scan, urinary marker, prediction of treatment response to select the right treatment for the patient. Second part is about the surgical approach on blood resection. We published a randomized trial in European Urology showing that we can reduce the recurrence rate at 1 year, but we're in the progress of doing an individual patient data meta-analysis and also having a global registry for real-world data, so likely that will influence practice guidelines. The third part is about how we can tackle the tumor heterogeneity. Because bladder cancer so far, the precision medicine has not been very successful. And my feeling is that because it is a heterogeneous tumor, conventional molecular classification, first of all, they will sample a sample from the tumor, a small sample of the tumor, and you assume that it represents the whole tumor. That's likely to be not true. So we're trying to do different ways to have a more broad assessment of the whole 3D tumor, so that not only we can classify the molecular features, but we have a 3D representation and also trying to quantify the heterogeneity, therefore hopefully can lead to a better precision medicine in the future.